A 76-year-old retired nurse named Beverly thought she understood hospitals. She had spent 32 years working in them. She knew the terminology, she knew the departments, she knew how care was delivered. What she did not know was how the billing worked. After a 2-day hospital stay in Charlotte, North Carolina for a cardiac procedure, Beverly assumed her Medicare coverage had handled everything. The hospital was in-network. Her doctor was in-network. She had done her homework. Over the following 6 weeks, bills arrived from 5 different providers she had never chosen, never met face-to-face, and in 2 cases had never heard of. A radiologist she had never spoken to, a pathology group operating out of a different city, an assistant surgeon whose name appeared nowhere in her memory of the procedure, a hospitalist group that billed separately from the hospital, and an anesthesiology practice that was out of network despite working inside an in-network facility. The total across all 5 bills came to $22,000. Beverly said, "I spent 32 years inside hospitals, and I had no idea this was how the billing worked. If I did not know, how is any patient supposed to know?" If you or someone you love has ever been inside a hospital, or ever will be, what you are about to hear could save your family thousands of dollars, prevent billing mistakes that pile up in silence, and give you the exact words you need to protect yourself before, during, and after a hospital stay. Today, we are going through the 5 biggest hospital billing traps that catch seniors off guard every single day across this country. For each one, you will learn exactly how it works, exactly what it can cost, and the specific words and actions that can protect you. We are counting down from 5 to 1. Stay with me all the way to the end, because the number 1 billing trap on this list has created bills larger than an entire year of Social Security income for seniors who never saw it coming. And almost every senior in America is vulnerable to it every single time they walk through a hospital door. Let us start. Most people think of a hospital bill as one bill, one facility, one stay, one charge. That is almost never how it works. When you are treated at a hospital, you are not just treated by the hospital. You are treated by a collection of independent providers who work inside that hospital, but bill completely separately from it. Your primary physician bills separately. The radiologist who reads your scans bills separately. The anesthesiologist who manages your sedation bills separately. The pathologist who analyzes any tissue samples bills separately. If a hospitalist physician managed your care during the night shift, they bill separately. If a specialist was consulted and walked in to examine you for 12 minutes, they bill separately. Each of these providers operates as an independent entity. Each has its own billing department. Each sends its own statement. And each may have a different relationship with your insurance plan. This means that a single 2-day hospital stay can generate 6, 7, or even 8 separate bills arriving in your mailbox over a period of weeks, each one carrying its own copayment, its own deductible calculation, and its own deadline for payment. Most seniors receive these bills and assume they are duplicates or errors. Some pay them without questioning. Some ignore them, thinking they have already settled their hospital account. And some discover months later that unpaid separate provider bills have gone to collections, damaging their credit and adding collection fees on top of the original charges. Arthur was 79 years old, a retired accountant from Denver, Colorado. He prided himself on financial organization. When he was discharged from the hospital after a procedure, he waited for his bill, received it, reviewed it carefully, and paid it in full within 2 weeks. 6 weeks later, a letter arrived from a collections agency. A radiology group that had billed separately had sent 2 statements to an old address in Arthur's file. Arthur had never received them. The balance was $840. By the time the collections letter arrived, late fees had been added, and his credit report had already been marked. Arthur said, "I paid my bill. I was careful. I did not know there were other bills coming from other directions. Nobody told me to expect them." Here is what you need to do before you leave any hospital. Ask the discharge coordinator or the billing department this question directly. Ask, "Can you give me a complete list of every provider who was involved in my care during this stay, including any independent groups who may bill separately, so that I know exactly how many bills to expect and from whom?" Write down every name on that list. And when bills arrive, match them to the list before paying anything. If a bill arrives from a provider not on your list, call and verify before paying. And say these words to your insurance plan after any hospital stay. Say, I want to verify that all claims from this hospitalization have been received and processed, including any claims from independent providers, such as radiology, anesthesiology, and pathology groups. That one follow-up call can catch billing errors, confirm network status, and prevent surprise collection notices before they ever reach your mailbox. Most seniors never make that call. Most seniors never know they should. But separate provider billing, as confusing as it is, gives you something to work with after the fact. The next trap is different, because by the time most seniors discover it, the financial consequences have already been locked in. We have talked in previous videos about observation status, the hospital classification that places you as an outpatient in the eyes of Medicare, even while you are sleeping in a hospital bed receiving around-the-clock care. Today, we need to talk about what that classification does to your bill specifically, because the numbers are significant and most seniors never see them coming. When you are classified as a hospital inpatient, Medicare Part A covers your stay. Your costs are structured around Part A deductibles and coinsurance, which your supplement plan may cover. Your prescription medications during the stay are covered as part of your inpatient care. When you are classified under observation status, everything changes. Medicare Part A does not apply. Your stay is billed under Part B, your outpatient coverage, which has different cost sharing. The coinsurance under Part B is 20% of the Medicare-approved amount, with no cap on total out-of-pocket exposure under Original Medicare. And your medications, the pills you take every day, the medications that are part of your regular treatment, may be billed to you as outpatient prescriptions at their full cost, because as an outpatient, Medicare does not automatically cover hospital-administered medications. Seniors have received bills for hundreds and sometimes thousands of dollars for medications they took during an observation status stay, medications they had been taking for years and had assumed were part of their covered care. Norma was 75 years old, a retired office manager from Salt Lake City, Utah. She was brought to the hospital after a dizzy spell and kept for 2 nights for monitoring. Her family was relieved that the monitoring found nothing serious. They left feeling grateful. The bills told a different story. Because Norma had been classified under observation status for her entire stay, her medications, including a blood thinner she had taken daily for 3 years, were billed to her as outpatient prescriptions at the hospital's retail pricing. Her total medication bill alone came to $1,200. Her overall out-of-pocket for the stay, which she had assumed would be minimal, exceeded $4,000. Norma said, "They told me I was being kept for observation, and I thought that just meant they were watching me. I did not know it was a billing category that changed everything about what I owed." Here is what you must do every single time you or a loved one stays overnight in a hospital. On the first day, not at discharge, not when the bill arrives, but on the first day, ask this question directly to the attending physician or charge nurse. Ask, am I currently classified as an inpatient admission or under observation status? And what does that classification mean for my Medicare coverage and my out-of-pocket costs for this stay? If the answer is observation status, immediately request to speak with the hospital's patient advocate and say these words. Say, I would like the attending physician to review whether my condition meets the clinical criteria for inpatient admission status, and I would like that review documented in my chart. That conversation on day 1 has resulted in status changes that saved families thousands of dollars. The same conversation on day 4 at discharge almost never does. Timing matters enormously. Do not wait. Ask the question the moment you or your loved one is settled into a hospital bed. But even if your status is correct and your coverage applies, there is a trap hiding inside the hospital's own billing system that most seniors never know to look for, and it inflates medical bills across this country every single day. Every hospital maintains an internal document called a charge description master. It is sometimes called the charge master, and it is essentially the hospital's internal price list, a list of every service, every supply, every procedure, and every medication the hospital provides, along with the price the hospital charges for each one. Here is what most patients never know. These prices are not regulated. They are not standardized, and they bear almost no relationship to what Medicare will actually pay or what a commercially insured patient will actually owe. Hospitals charge the charge-master rate as a starting price, knowing that insurance contracts and Medicare rules will reduce that price significantly for insured patients. But for patients who are uninsured, underinsured, or who receive services outside their coverage, the charge-master rate may be what they are actually billed. The markups in charge-master pricing can be extraordinary. Common supplies charged at many times their actual cost. Medications billed at prices far above pharmacy retail. Procedures priced in ways that bear no visible relationship to the cost of delivering them. And when billing errors occur, when a service is billed that was not actually provided, or when a service is billed under the wrong code, those errors are billed at charge-master rates. A billing error involving a procedure that should have cost $200 may appear on your bill as $2,000, charged at full price. Studies have estimated that a significant percentage of hospital bills contain errors, and the vast majority of those errors are overcharges rather than undercharges. Most seniors pay these errors without ever knowing they exist. Jerome was 73 years old, a retired pastor from Atlanta, Georgia. He received his hospital bill after a 3-day stay and noticed that the total seemed higher than he expected. He almost paid it without question because the insurance had covered most of it and his remaining balance felt manageable. His son, who worked in finance, encouraged him to request an itemized bill. When the itemized bill arrived, they found charges for 4 days of a medication Jerome had only received for 2 days. They found a charge for a consultation that Jerome's physician confirmed had never taken place. And they found a supply charge for a category of medical equipment that Jerome had not used during his stay. The corrections to those errors reduced Jerome's bill by over $2,000. His son said, "My father almost paid it. He thought because insurance had processed it, someone had already checked it. Nobody checks it. That is your job." Here is what you need to say to every hospital billing department after every stay. Say, "Before I pay any balance on this account, I am requesting a complete itemized bill that lists every charge individually by date, service, and billing code. I will review that itemization before making any payment." You have the legal right to an itemized bill. Every hospital is required to provide one upon request. And the process of reviewing it line by line, or having a family member review it, is the most direct way to identify and correct billing errors before you pay them. This is not about distrusting hospitals. It is about understanding that billing departments process thousands of claims, and errors occur. Catching those errors is your responsibility, because no one else will catch them for you. Most seniors never request an itemized bill. Most seniors never know they can. You now know. Use it. Have you ever received a medical bill that shocked you? A charge that seemed wrong, or a total that was far more than you expected? Tell us in the comments. Your experience could help another senior know exactly what to look for. But billing errors on your itemized statement, as common as they are, can be corrected once you find them. The next trap on our list is different, because this trap does not involve an error. Everything on the bill is technically correct. The provider performed the service. The service was billed accurately, and yet the bill can still come to tens of thousands of dollars that no senior should ever have to pay. This is the #1 hospital billing trap in America, and it is completely legal. You arrive at a hospital that is in-network with your Medicare Advantage plan or your supplemental coverage. You verified this before your procedure. You did your due diligence. You feel protected. What you did not verify, and what almost no patient thinks to verify, is whether every individual provider involved in your care is also in-network. Because here is the reality of how hospitals operate. The hospital itself may be in-network. Your surgeon may be in-network. But the anesthesiologist who puts you to sleep is employed not by the hospital, but by an independent anesthesiology group that negotiates its own insurance contracts. That group may not be in network with your plan. The radiologist who reads your postoperative scans may be part of a radiology firm that operates across multiple hospitals and is out of network with some of them. The assistant surgeon who helped with your procedure may be a contracted physician who is not credentialed with your specific insurance plan. You never chose these providers. You never called their offices. You never had any interaction with them that would have allowed you to check their network status. They appeared in your care automatically as part of the system that surrounded your procedure. And when their bills arrive, the fact that you never chose them provides very little legal protection. The No Surprises Act, passed in 2022, provides some protection against out-of-network billing in certain emergency and non-emergency situations, but it has exceptions. It does not cover all plan types. It does not protect against all provider categories, and the process of invoking its protections requires knowing the law exists and taking specific steps before or immediately after service. Most seniors know nothing about the No Surprises Act. Most seniors find out about out-of-network providers the same way Beverly did, when the bills arrive in the mailbox, weeks after the procedure, when the care has already been delivered and the providers have already been paid by your insurer at whatever rate they negotiate. Eileen was 72 years old, a retired social worker from Pittsburgh, Pennsylvania. She had scheduled a hip replacement at a hospital her Medicare Advantage plan fully covered. Her orthopedic surgeon was in network. She had called her insurance plan 3 times to confirm coverage. She felt completely prepared. What she did not know was that the anesthesiology group contracted by that hospital to provide anesthesia services had recently ended its in-network relationship with her Medicare Advantage plan. The hospital had not updated its patient-facing information to reflect this change. The admissions coordinator had not been informed. And Eileen had no way of knowing that the person responsible for keeping her alive and pain-free during her procedure would send her a bill that her insurance would treat as out-of-network. Eileen's anesthesiology bill was $14,000. Her plan's out-of-network coverage applied a dramatically different cost-sharing structure. Her personal responsibility was $8,200. She had budgeted for a procedure she believed would cost her under $1,000 in out-of-pocket costs. Eileen said, "I called my insurance 3 times. I confirmed everything I knew to confirm. I did not know there was something I did not know to ask about." And that is the heart of this trap. It is not that seniors fail to prepare. It is that most seniors do not know that individual providers inside an in-network hospital can be out-of-network. It is that most seniors have never heard the term anesthesiology group and do not know that this group may operate independently of the hospital's contracts. Here is what you must do before any scheduled hospital procedure. Not on the day of, but days or weeks in advance when you still have time to act. Call your insurance plan and say these words. Say, "I have a procedure scheduled at this facility on this date. I need you to help me identify every provider category that may be involved in my care, including anesthesiology, radiology, pathology, and any assistant surgeons, and I need to verify the in-network status of each provider group contracted by this hospital for these services." Your insurance plan has this information. They can run a network check by facility and by provider category. It takes time and persistence to get through to a representative who can do this thoroughly, but the information is available. Also say these words directly to your surgeon's office before your procedure. Say, "I need the names of the anesthesiology group, the radiology group, and any other independent provider groups that will be involved in my procedure so that I can verify their network status with my insurance plan before my surgery date." A surgeon's office that handles many patients will know exactly which groups they work with. Most will provide this information immediately when asked. Some will need a few days to confirm. And if you discover that a provider involved in your care is out of network, you have options before the procedure takes place. You can request that the hospital or your surgeon arrange for an in-network alternative. Under the No Surprises Act, for certain non-emergency procedures, you can also request that an out-of-network provider agree in advance to charge only in-network rates. Get that agreement in writing before your procedure date. These steps require time, and they require asking questions that most patients have never thought to ask. But the alternative is an $8,000 bill arriving in your mailbox after a procedure you thought was fully covered. And once that procedure is complete, the leverage you had before it disappears entirely. Before we close, here is your hospital billing protection plan. The exact words that can protect your finances before, during, and after every hospital stay. For separate provider billing, say, "Can you give me a complete list of every provider involved in my care during this stay, including independent groups who may bill separately, so I know exactly how many bills to expect?" For observation status billing, say, "Am I currently classified as an inpatient admission or under observation status? And what does that classification mean for my Medicare coverage and my out-of-pocket costs?" For ChargeMaster overcharges, say, "Before I pay any balance, I am requesting a complete itemized bill that lists every charge individually by date, service, and billing code." For billing errors, say, "I want to review this itemized bill line by line before making any payment, and I am requesting a 60-day hold on this account while I conduct my review." For out-of-network specialists, say, "I need the names of every independent provider group involved in my procedure so I can verify their network status with my insurance plan before my surgery date." Write these down. Save them in your phone. Share them with your children and your spouse. Because the hospital billing system is not designed to protect you. It is designed to process claims efficiently. Your protection is your responsibility, and you now have the words to provide it. Most seniors who pay surprise hospital bills did not fail to prepare. They simply did not know what they did not know. You now know, and that knowledge, used at the right moment, is worth thousands of dollars. If videos like this help you protect your health, your finances, and your peace of mind, please subscribe and join us. We are here every single week with information that the healthcare system does not go out of its way to explain. Because in our next video, we're exposing a 5-minute hospital mistake that can cost seniors $20,000. A mistake made not by doctors or nurses, but by patients themselves in the first moments after they arrive, before a single test has been run or a single treatment has begun. You will not want to miss it.